Go ahead, Dr. Mojar. You can start with the introduction. You have about 4 minutes, and I'll be keeping time.
Okay, so I'm ready to start. So,
good afternoon, everybody.
Good afternoon, everybody. It's a pleasure to be here with you. This is a very special occasion since we're going to have, for the first time, this virtual meeting for all Latin America. And it's particularly important because we're going to have an extraordinary program today where we're going to have, I will say, 3 big chapters. One of them is basically to discuss 2 of the ongoing protocols that have been already accepted and where we have been recruiting patients in different countries in Latin America, particularly in Mexico, in Peru, in Colombia, and hopefully in Chile, and hopefully soon in Uruguay as well. And also, we have the opportunity to discuss directly with the PI of these protocols. Any questions? How is the recruitment? How are the results expected? And any questions, comments, suggestions of the PIs who are present now in this meeting to our leaders of these 2 protocols. So I just want to thank you again, the wonderful organization, which has been complicated to set up all Latin America and together with the CRAB and with the PIs of these protocols to have the opportunity to share the ideas and how it's ongoing with these 2 protocols, which are key for the participation of Latin America in the SWOG clinical trials. Then we're going to have a short discussion within the Latin American PIs of a group of ideas of what we can do together in Latin America as a group within the own pathology that is prevalent in Latin America. And as you know, basically it's advanced stages of the disease, cervical cancer, gastric cancer, lung cancer, and also this type of malignancy is seen in other parts of the world, like breast cancer, colorectal cancer, and of course, lung cancer. However, the big difference is basically the delay of the diagnosis, the access, the optimal access to optimal treatment. And this is a big issue that we would like to discuss with some particular ideas that we're going to present, particularly from the NCI. Dr. David Cantu is going to present some ideas of a proposal that he has, hopefully to set up a joint collaboration with Latin America and the SWOG of cervical cancer. And after having these opportunities to hear from both PIs, what will be the future of these trials and any ways that we can strengthen the participation of Latin America in this, and after seeing our own discussion, our own ideas, we will finalize with the presentation of Dr. Gabriela Mora, which is one of the clinical research associates, I will say the senior of the Latin American initiative, where she's going to explain us what are all the paperwork, the timing, and the requirements for Latin America to update our membership, to not lose the opportunity to be part of slides, since sometimes we can miss an email or a paper that we have to submit to the SWOG, to the operational office, or as well to the NCI of the United States, and then we are delayed in the authorization of setting up patients. So we're going to have as well a very short discussion and presentation from Dr. Mora to discuss these issues. And then finally, if timing is allowed, we're going to have the opportunity as well to wrap it up and of course see what's the next steps for the future of this Latin American issue. So in the 45 seconds that I guess Dacia has allowed me to conclude, I would want to thank you again to everybody to be here. It's a real pleasure and a wonderful experience to being so many people here discussing this in this symposium. That is not possible if we go to San Francisco or to Chicago. And of course, invite you, to all of you, to our important course next week on clinical trials that is not based in Mexico City, but is coordinated at the Mexican National Cancer Institute. So thank you all, And please, Dacia, continue with the agenda of this important symposium, and welcome all again. Un abrazo a todos.
Thank you, Dr. Mojar. Our next presentation is by Dr. Meghna Trivedi, the principal investigator of S1714. Okay, so we have 9 to 10 minutes of presentation and about 4 to 5 minutes of discussion. And the slides will be centrally controlled with the IMS computer. And please use a verbal cue to change
Sure, great.
slides. Thank you.
Thank you so much for inviting me to talk about S1714, and we're so excited to have the Latin American sites participate in this trial. So my name is Meghna Trivedi. I am one of the PIs on this study, a prospective observational cohort study to develop a predictive model of taxane-induced peripheral neuropathy in cancer patients. And we all know that chemotherapy-induced peripheral neuropathy, or CIPN, is a frequent side effect that we have from the administration of our cytotoxic chemotherapy agents, and we're hoping that this observational cohort will allow us to develop a clinically meaningful prediction model. Next slide, please. The study objectives are listed on the slide. So the primary objective is to develop and validate a clinical risk prediction model using clinical factors for the development of peripheral neuropathy in patients receiving taxane-based chemotherapy regimens. We also have several secondary objectives, including using various PROs and objective measures of CIPN to better define the phenotype of peripheral neuropathy in this patient population, to look at the incidence of CIPN in this patient population, and to identify the predictors of treatment dose reductions, delays, and discontinuations that are associated with CIPN in this population. We're also building a serum and plasma sample biorepository for future biomarker and mechanistic studies of CIPN, and our translational medicine lead on that is Dr. Dan Hertz. Next slide, please. The study itself is fairly simple. It is an observational cohort study, so we are including non-metastatic, essentially stage 1, 2, and 3 primary non-small cell lung cancer, primary breast cancer, and primary ovarian, peritoneal, or fallopian tube cancer patients. There's a baseline evaluation looking at the primary endpoint, which is the CIPN-20 PRO, as well as biospecimens collected, other PROs, and then sensory and functional testing. As part of the translational medicine objective, we are also collecting biospecimens at the end of taxane cycle 1 for PK analysis. Then finally, next at weeks 4, 8, and 12, as well as 24, 52, 104, and 156, so up to 3 years after registration, we will continue to follow these patients with various PROs and assessments by the physician and staff, as well as sensory and functional testing. Next slide, please. The eligibility for this trial is fairly wide open, so adults over the age of 18 who are starting primary treatment for, again, non-small cell lung cancer, breast cancer, or ovarian, fallopian tube, and primary peritoneal cancer, who are receiving one of the study-approved taxane-based regimens. They should not have received prior taxane or platinum or bortezomib-based chemotherapy. They should have good hepatic, hematologic, and renal function to administer chemotherapy at the discretion of the treating physician. Of course, be able to provide informed consent, and importantly, pre-existing neuropathy does not preclude participation in this study. Next slide. This is a table of the timeline and assessments. So as far as the PROs, we are, again, collecting the CIPN-20, which is the primary endpoint. We're also looking at the PROMIS-29, a symptom and side effect burden score, a physical activity questionnaire, the PRO-CTCAE, and then the FACT-NTX score. The biospecimens are listed here as well, and at the time points at which they are collected. Only 2 of the biospecimen submissions are mandatory. The remainder are optional, but we are asking that study teams try and coordinate the collection of these biospecimens at the same time as the routine labs for treatment in order to minimize patient discomfort. Uniquely for the study, we're also doing neurosensory testing and functional testing, and I'll talk a little bit more about that in the next slide, but we will be using the NeuroPen and tuning fork in order to perform neurosensory testing, and this is done, again, across multiple time points over the observation period. In total for the patient time burden, so the total time for questionnaires for patients is around 25 minutes, and the total time for the sensory function and functional assessment testing at each time point is about 15 minutes. Next slide, please. So again, the neurosensory assessments are unique to this protocol and do require some specialized equipment and training. The instructions on how to request the tools are in the protocol, but basically you would send an email to our S1714@SWOG.org listserv and request the tools be sent to you. The 2 tools are the NeuroPen and the tuning fork. In order to complete these assessments, clinicians must be trained and certified by the study team. And so this can be done by first reviewing the instructions in the protocol and watching the instructional video. Then you can request a direct observation over Zoom in order to demonstrate your proficiency to a study team member, and then you'll be provided with a certificate of training that will be submitted to the CTSU website. And then last slide. So again, this trial has done very well with accruing. We've been very thankful for all the sites. We have 112 sites open in total. We're currently reviewing the data in order to see if we need to make any changes to our accrual goal. But again, we look forward to having we are very happy to have the Latin American sites participating. And if there are any questions that don't come up right now and you have in the future, please feel free to email our listserv, and hopefully we have some time for a few questions.
Thank you, Dr. Trivedi. We have 6 minutes for questions. You can ask the questions in English or Spanish, okay? And if you ask them in Spanish, you can write them in the chat and we'll translate for you.
I would like to make a comment. It's not actually a question, but I would like to thank you for this trial, because in our institution, we have already, National Cancer Institute, Mexico, we have already recruited, I think more or less 30 patients, and it was very interesting to see how in the clinical practice we forget to evaluate the neuropathy in these patients. So our fellows and our physician assistants and our medical staff is now very concerned about the importance of testing how is the neuropathy going in our patients. So thank you very much for this initiative. It will be a very, very good job for our care for our patients.
Great, thank you so much for that comment.
Hi, does I have a question, Alejandro Moar, very quick. In terms of the serum samples that you are thinking and that we are collecting, is there any specific hypothesis or objective to look for a biomarker that could evaluate a little bit more this association of neurotoxicity? Thank you.
Yeah, Great question. So Dan Hertz, again, is the translational medicine lead on this, and he's done a lot of work in particularly taxane-induced peripheral neuropathies. And so we're working on a proposal right now to try and see what we can look for. He's particularly interested in metabolomics as well as pharmacogenomics and pharmacokinetics aspect of looking for biomarkers.
Thank you. ¿Alguna otra pregunta en español? Si se animan, aquí les traducimos.
We have a question in the chat from Dr. Mora. The time patients will be participating just changed. Could you please explain this?
Yes, so that's a good question. I think it was not the most recent revision, but the revision prior to that, we did extend the time period for following the patients. And the reason we did this is there is an ongoing ECOG-ACRIN trial with a similar patient population, and we wanted to try and harmonize it. It's the EAZ-171 trial. And that study is looking at taxane peripheral neuropathy in African-American patients with breast cancer. And so in coordination with that study, we thought it would be helpful to have similar time points as well as similar patient-reported outcome measures in order to kind of build our efforts to better understand peripheral neuropathy. And so that was the reason why we extended the time points and also included the FACT-NTX4 as one of the PROs.
We have time for one more question. Does anyone have any questions?
I don't know if Dr. Sandy Reese has a question because she is the one who is helping us with the Accura with the patients. Do you have any concerns, Dr. Reese, or everything is okay? I think everything is okay.
Okay, great. Thank you very much, Dr. Trivedi. And this is the email we use for any future questions, the one that's on the screen right now.
Thank you
Yes,
so much.
absolutely.
Perfect.
Thank you.
Thank you. Thank you.
Great. Thank you very much.
All right, to continue, we're going to invite Dr. Chad Rusthoven, who's the principal investigator of 1827 to speak. It's also known as Maverick. Dr. Rusthoven, you have until 5:32 to present, so plan on about 9-10 minutes, and then we'll have 4 to 5 minutes of questions at the end.
Great. Thank you so much for the opportunity.
Oh, we're having a sound issue, I think. I can't hear you too well.
Are you able to hear me at all?
Yes, now I can hear you. Thank you.
Okay, great. And then will you be controlling the slides centrally?
Oh, yes. The slides will be centrally controlled from the IMS computer system. So just say next slide when you're ready.
Okay.
Thank you.
Would you like to pull up the slides for the trial?
Yeah, can the person in charge of the computer pull up the slides? Thank you.
Thank you. So thank you again for the opportunity. My name is Chad Rusthoven. I'm a radiation oncologist at the University of Colorado Hospital, and I'm the principal investigator of this trial, the SWOG S1827 study. And this is a study for patients with small cell lung cancer, and it's a randomization to brain MRI surveillance plus or minus prophylactic cranial irradiation. And I've had the privilege of working on this with this great study team here. And the study was activated last year, and we have been working to open the study up to our SWOG international sites, and currently have an amendment under review that hopefully will be approved within the next week or two to allow Latin American sites to begin opening it. So very grateful for the opportunity to present the trial here. Next slide. So by way of background, PCI, prophylactic cranial irradiation, has been a staple of small cell lung cancer management for a number of years. And I'll just briefly go over the history here and why we're interested in asking this question. So it was recognized in the 60s and 70s that small cell lung cancer had a high propensity for brain metastases, and so different strategies were developed to try to address that. And the most prominent strategy was prophylactic cranial irradiation, which is essentially whole brain radiation in patients without identifiable brain metastases, with the presumption that there's already microscopic disease in the brain and that delivering this therapy could reduce the incidence of brain metastases. And sure enough, that's what the early studies showed. There was very consistent decreases in brain metastases. But we also began to understand that there was toxicity associated with this treatment. The PCI became a standard therapy in small cell management after a couple of landmark studies were published in the New England Journal of Medicine. The first was a meta-analysis published in 1999 by Operin and colleagues, and that was a study of primarily patients with limited stage disease. And then there was a subsequent study that was a dedicated randomized trial performed in Europe by the EORTC specifically in patients with extensive stage disease. And both of these studies demonstrated an improvement in overall survival. And after that was observed, then prophylactic cranial irradiation became really a standard therapy for both limited and extensive stage disease. Both of these studies had some limitations, and primarily one of the primary limitations was heterogeneous and often absent brain imaging and brain surveillance. And so to address these limitations, there was a dedicated study in extensive stage that was performed in Japan and that was published relatively recently in the Lancet Oncology in 2017. And that study, in that study, all patients underwent brain MRI staging as well as surveillance, and then they were randomized to PCI versus no PCI. And what they found was that in the context of that randomization, there was no differences in progression-free or overall survival with the addition of PCI. And so these were interesting results, and they suggested that in the context of brain MRI surveillance, that we may be able to identify brain metastases sooner and offer more effective salvage therapy. And in that context, it's possible that PCI might not result in an overall survival benefit. And so here are the primary curves from the European study and the Japanese study, both in extensive stage small cell lung cancer. In the European study, when patients were just observed and there was no brain MRI surveillance, the addition of PCI resulted in a survival benefit, whereas in the Japanese study, in the context of MRI surveillance, there was no survival benefit with PCI. Next slide. And so this leads us to today in 2021. So here are the NCCN guidelines, and just to review kind of what's considered standard today. So in the green boxes, we have limited stage disease where prophylactic cranial irradiation remains a Category 1 recommendation for patients who have had a response to first-line therapy. And so why is that? Well, the aforementioned meta-analysis published in 1999 remains the best data on this topic for limited stage disease. And so PCI is still considered the standard of care. Whereas in extensive stage disease, the NCCN guidelines give the option of delivering PCI. And the reason for that is we have conflicting survival data from the European and the Japanese studies. And so it's considered a standard option, but it's not mandated as a Category 1 recommendation. And then over in the purple box to the right, in response to the Japanese data, MRI surveillance is recommended for all patients, regardless of whether they receive PCI. And the NCCN recommends MRI surveillance every 3 to 4 months during year 1 and every 6 months during year 2. Next slide. And so that leads us to the current trial, which is SWOG S1827, the so-called Maverick trial. And again, this is brain MRI surveillance versus MRI surveillance plus prophylactic cranial radiation. And it's a randomized phase 3 trial for small cell lung cancer patients. And on the left, we have the basic inclusion criteria. So this study includes patients with both limited and extensive stage small cell lung cancer who have no brain metastases previously, so no brain metastases at diagnosis, as well as no brain metastases after first-line therapy. And then it's a very straightforward design. So all patients receive brain MRI surveillance, and it's a simple randomization to prophylactic cranial irradiation versus not. And then patients will be followed and undergo surveillance every 3 months during year 1 and every 6 months during year 2. The primary endpoint of this study is overall survival, and there are a number of secondary and translational endpoints as well. The study is designed to be very flexible. So for centers that are interested in doing hippocampal avoidance, PCI, that is allowed on the study. We also allow pretty much any and all types of first-line therapy for limited and extensive stage disease. As people on this call are probably well aware, the therapies for small cell lung cancer are continuing to evolve. Immunotherapy has become a standard option for extensive stage disease, and certainly we want to be welcoming to any first-line therapies that would be offered today, as well as things that may evolve over time. And so that's the basic schema. Next slide. And then here are just some general notes on this study. So we're trying to cast a very wide net in inviting different cooperative groups and centers to participate in this study. So it's fundamentally a study led in SWOG, but the study is also open in Nrg, Alliance, ECOG, and the CCTG. And we also have dedicated championing in the Veterans Administration system here in the United States. As I mentioned at the beginning, there's an amendment that's currently under review at the NCI to open the study up to our international partners, and we're very excited about that. One specific difference with the international site participation is that international sites will not be asked to complete cognitive testing for this study. So there's a long explanation for this, but one of the points is that the cognitive tests have not been validated in languages other than English and Canadian French. And so that will just not be a part that's asked of the international sites, but that in some ways actually makes it easier to participate in because there's less credentialing. It's a very straightforward study for international sites to participate in. It's brain MRI surveillance plus or minus PCI. And then, as I mentioned, the trial design was designed to minimize barriers to accrual and to be very accommodating to different practices in small cell lung cancer. And so those are the things I wanted to go over, and my email is listed here. And so if you have any questions, I'd obviously be happy to answer them now, as well as after. If you think of any, please feel free to email me. And with that, I'd love to open it up to any questions.
We have about 5 minutes for questions. Please feel free to write the questions either in English or Spanish in the chat.
Thank you so much for your presentation. Very, very interesting. Well, I do breast cancer, but sounds very interesting. My question is, what are the barriers to accrual that you have already detected with this trial?
That's a great question. So a couple of the barriers that we have encountered, one is a barrier that all studies in this era have faced, which is the local research limitations in the COVID era. So this study was activated right before the COVID pandemic hit, and that slowed things down a little bit. But that's a kind of a universal thing, and we're hoping that improves. Some of the other barriers specific to this trial There are several trials in the small cell space that are active and accruing in the United States. There's an Nrg trial, LU005, which is a really great trial for limited stage small cell lung cancer that's chemo radiation plus or minus immunotherapy. And so obviously that's a trial of interest. There's another PCI trial that's actually almost completed successful accrual that's looking at PCI with or without hippocampal avoidance that's being led through the Nrg. And so that study will probably be fully accrued within the next few months. And so we're hoping to present our trial as a kind of a natural successor trial to that and try to get some of those sites to buy into this question, because if hippocampal avoidance is helpful, then the natural next question would be MRI surveillance plus or minus hippocampal avoidant PCI. And this study does allow that, and we've been tracking that prospectively already. So it could be a natural follow-up. And then I think the third and perhaps the most important barrier is that in some ways this is a difficult randomization because it's a brain radiation versus no brain radiation randomization. So just when you present that to patients, it's that's a harder thing to present to patients than say like a immunotherapy access trial or a brain radiation trial that's testing a new technique to have less toxicity, because patients can actually have MRI surveillance or PCI off trial. And so I think that the framing and really actually the education for the patients is a very important aspect of presenting this trial and developing interest. One of the things that I've learned in presenting this trial to patients over the last year is, I try to present the data and say, PCI consistently reduces brain metastases. It cuts them in half in just about every prospective trial that's ever been done over the last several decades. And so for some patients, that's really important. And so that's it's important to tell patients why we do PCI in the first place, and then that we have conflicting overall survival data. And we're trying to figure out if really this is the right thing to be doing over the next generation. PCI is a category 1 recommendation for patients with limited stage disease. And so that's the standard of care. And this is the first time that a trial has ever asked the question in limited stage whether or not we can do MRI surveillance alone. And so the MRI surveillance arm is truly the experimental arm. And so I think that's an important way of framing the question when you're talking to patients, because it's saying, we think that this might be okay. The best way and the preferred way to do the MRI surveillance really would be in the context of a phase 3 randomized trial where there's close surveillance and we're tracking those outcomes. And we're also helping the next generation of patients with the information that we gather. So I think taking time to not bias the patients, but to present them with a balanced understanding of why we've done PCI in the past, why we're asking this question again, I think is really, really important. And that's something that I've personally learned in just presenting the trial to patients over the last year.
Okay, thank you so much. And actually, the patients are living longer as breast cancer HER2 positive patients. So it's the concerns about quality of life are very important. Thank you.
Thank you. Thank
you. Very, very important. I have one comment from Dana Sparks that I want to bring to everyone's attention. In section 13.2b.3 of the protocol, all sites can find what certificates have to be submitted on the CTSU portal for this study. So you have to submit some training certificates to be able to participate. Okay.
This comment was for 1714.
Oh, 1714. Sorry, I missed that. Thank you. Thank you, Dana. Okay, we're going to move on. Thank you very much, Dr. Rusthoven. And the next presentation is a roundtable discussion. And our first presenter will be Dr. Cantu of the National Cancer Institute in Mexico. Okay, and he'll be using his own slides.
Hello.
Dr. Cantu, we cannot hear you if you're speaking.
Hello, can you hear me?
No, we can hear you. Thank you.
Can you hear, can you see my presentation?
I can see you, but not your presentation.
Let me see.
Now we can
I think,
see it's starting to share your screen now.
okay. Something is moving slow. I don't know what's happening.
In the meantime, Deja, that hopefully the slides will come up. I just want to introduce briefly Dr. David Cantu. He's a trained oncologist at the Mexican National Cancer Institute. Currently, he's the director of research of the Division of Research of the Mexican NCI, and she has published extensively in cervical cancer and in other gynecological malignancies. So the presentation that he's trying to give today, it's a protocol that indeed has already been submitted to Dr. Crowley for his comments, and I'm pleased that he has the time and interest in presenting it here to all of us, since I'm sure it's an opportunity for Latin America to collaborate in this, as we are making this retrospective analysis with Dr. Velasquez from Colombia in the recruiting more than 1,000 patients retrospectively on the clinical response and survival of cervical cancer. So David, if for some reason will not show up, it's a pity because you already have it on the screen.
Yeah, something happened here. I don't know what exactly it is. I'm terribly sorry for this problem, this technical problem. But what I want to share with you is an idea that we have here at the National Cancer Institute in Mexico. Is a phase 2 randomized clinical trial that we are starting to conduct. It is related to locally advanced cervical cancer. And what we are trying to do is to see the safety and efficacy of hypofractionation combined with brachytherapy for locally advanced disease. And patients are randomized to receive this treatment or to have the standard treatment. As you all know, locally advanced cancer, cervical cancer, the treatment is chemoradiation, external beam chemoradiation, plus brachytherapy. A standard treatment consists in 50 gray divided in 25 fractions. And what we are trying to do is to reduce the number of fractions to 3 weeks instead of 5. This is not new. This kind of treatment has been proved in other diseases, just like breast cancer, colorectal cancer, non-small cell lung cancer, glioblastoma, and breast cancer, as you know. In cervical cancer, there is few evidence that this kind of approach can be used. There are few retrospective studies. We were able to find no more than 6 retrospective studies in the literature. The newest one was published 5 years ago in a group of 40 patients that received 45 gray in 18 fractions. The largest project that we were able to find is an Indian protocol in patients with stage 3B and included no more than 60 patients.
Perdón,
Therefore,
David, te interrumpo. Si tienes tu presentación, mándamela ahí a la mano y yo la mando ahí al área central para que podamos hacerlo. Ahí está, creo que ya me apareció. Ahí está. Ya llegó. Gracias.
all right. Okay, this is what I was trying to explain, that there are no more than 6 projects in this field, and As I said, there's an Indian project with 62 patients. Next slide, please. As I mentioned, there are no prospective data regarding whether hyperfractionated radiotherapy is equivalent to conventional radiotherapy in terms of effectiveness and safety in cervical cancer. This is very important because in Latin America and in other areas, the number of trained personnel and equipment to manage this kind of disease is not available. Therefore, there is a delay in the initial treatment of patients, compromising the treatment and the results and the prognosis of these patients. I have the next slide, please. With this information, we propose this project with this hypothesis that the safety and efficacy of hypofractionated radiotherapy with concurrent platinum-based chemotherapy followed by brachytherapy is similar, or at least not worse than the standard concurrent chemotherapy followed by brachytherapy in patients with locally advanced cervical cancer, specifically stage 3 disease. I have the next, please. The primary objective of our study is to see acute and late toxicity, and the secondary objectives are the efficacy, of course, disease-free survival rate, the overall survival, the quality of life assessed by the patient and assessed by the physician, and we will try to detect direct and indirect costs of related to treatments. May I have the next? As I mentioned, this is a randomized phase 2 study that we will try to include this group of patients, stage 3A. As you know, this stage is not very common, but we will try to get some cases. Stage 3B, and with the new FIGO staging, stage 3C1. In this group of, in this case, we will not include a stage 3C2 because of the size of the fields that have to be used in the radiotherapy external beam fields. In the standard arm, we will include 25 fractions for 5 weeks, plus cisplatinum, 40 milligrams per meter square. And then the experimental arm, we will use the same dose of platinum, and we will reduce the number of fractions to 15 fractions with a radiobiological dose of 37.5 grays. And this will be the advantage of using this technique. After that, all patients will go to 4 sessions of brachytherapy of 7 grays. At point A, they will receive 28 grays, which is the standard for this stage of disease. May I have the next slide? We will try to include 82 cases, 41 to each arm. The basic inclusion criteria are these that you can see. Women of 18 years old or older, patients with the stage 1 from 1B3 to 3C1 of squamous or adenocarcinoma of the cervix, with no disease outside of the pelvis or distant metastasis by CT or PET-CT, with a good performance status. And of course, all patients must provide a study, an informed consent before being included into the protocol. The exclusion criteria, next slide, please. They are those patients with previous cervical cancer or with previous disease that had pelvic radiation, or prior allergic reactions to cisplatin or other platinum-based drugs, and of course, patients with peri-aortic nodes or distant metastases. Next. Next. As you know, this kind of approach is not approved and is not the standard of care. But what we want to prove is that it's efficacious and is not more toxic than the standard treatment. And we are open to questions.
Hi, I'm Javier from Chile. Can you hear me?
Sure.
Yeah, I have a lot of questions for your trial. First of them is, so if you're planning to do the radiotherapy in just 3 weeks, you're planning to do 2 weeks of chemo without radiotherapy, right?
No, we are planning to give 3 weeks of chemotherapy for those patients in the experimental arm. In the standard treatment, the patients at least must have 3 weeks of chemotherapy.
So I have more questions now because as we have already seen in the Embrace trials, in different trials, the tumor reduction, the tumor volume reduction, it's something like along the weeks, you get more tumor volume reduction to the brachytherapy. So if from the data, we know that after 30 gray, the tumor reduces like 50%, and after the 5 weeks of treatments before the brachytherapy, the tumor reduces like 75% of the volume. So if you're planning to do the radiotherapy in just 2 weeks, do you think you're going to be able to give the brachytherapy after that? That's my first question. Sorry. My second question is, when you, with that fractionation, with an alpha beta of 10 for cervical cancer, you are giving less radiation in the hypofraction arm. So aren't you afraid of giving less radiation dose to a tumor that you know is dose responsive?
Yes, these questions are very interesting, of course. What our radiotherapist evaluated, the difference between the standard arm and the experimental arm, they consider that the radiobiologic dose was similar in both arms.
Today is Earth Day.
Therefore, this concern about the dose of radiation is already solved by our radio-oncologists and the physicists. The other question that you had about the number of weeks, we didn't see that, and at the present moment, we are not concerned about that. But we have to review it, of course.
Great. Thank you very much for your presentation, Dr. Cantu. Perhaps we could continue this discussion in one of our clinical trial working groups meetings that we have monthly. And Dr. Mora could invite you, and some of the same investigators would be on who might be interested in hearing more about the trial.
Certainly.
Thank you.
That would be great. Thank you very much for your presentation. And we hope to see you at the next meeting, perhaps.
Thank you.
Dr. Mora, Dr. Mora is going to present now and give us an administrative overview of international site participation in SWOG trials and how to maintain membership. This part of the presentation will be in Spanish, but her slides are in English. So hopefully you'll still be able to follow if you don't speak Spanish.
Good afternoon, everybody. Just 1 minute, please. Well, 1 second.
So you can say it in English, Gabriela, now that we have a lot of colleagues from the US still here with us. And if there's any questions of our colleagues, they can say, ask you in Spanish. So please go ahead, Gabriela.
Okay. I'm going to talk a little bit about the role of the principal investigators, as this was a topic asked by Dr. Cabrera. So, and this is very important so that you as principal investigators know what responsibilities you have for SWOG. Here you have, I'm not sure if you are watching my slides. Is it okay?
Yes, we are hearing you and watching your slides, Gabriela, so please continue.
Okay, thank you. Okay, so here we have the general responsibilities. Here the PI, first of all, we call PI to the principal representative physician at each institute to represent their institute for SWOG. So the PI will assume responsibility for the overall scope of his or her institute program, ensuring that the institution meets the procedures and standards set forth by SWOG, notifying SWOG of important changes in member relationships, agreeing to quality assurance audits, communicating all policies and any changes in policies, on the conduct of clinical research to clinical researchers and staff members. The PI will promote SWOG activities within the institution, ensuring investigators and trainees are provided the opportunity to learn about SWOG and participate in SWOG activities. The PI will also identify institutional research that could be translated to cooperative group science and assisting in bringing those ideas forth within SWOG. Okay, some specific responsibilities are the next one. It's understand and uphold the policies and procedures of the group and assist with and participates in communications as necessary. Ensures that specialists from relevant oncology disciplines, as well as appropriate data management and nursing resources, are available within the institution to support the activities of SWOG. Regularly monitors institutional accrual and ensures the institution meets minimum accrual goals set forth by SWOG to maintain membership. Monitors performance of affiliate sites and provides support to those sites as needed. Directs the use of funds received by SWOG to support SWOG activities. Assumes patient follow-up responsibility from investigators at his or her institution or affiliates in accordance with group policy number 30. Principal investigator is expected to be available during the exit interview for a recap of the audit findings and to provide clarification of issues raised by the auditors. Ensures that deficiencies in institutional performance reviews and quality assurance audits are addressed and corrected. Approves all new investigator membership nominations at his or her institution and affiliates. Appoints individuals from his or her institution as authors on group publications in accordance with group policy number 24 as requested. it is required that the principal investigator that attends at least one semi-annual group meeting every 2 years. Principal investigators that have met accrual and scientific standards for governing membership have been nominated by the professional review committee and have been approved by a majority of the standing board of governors will serve on the board of governors for 2 years. I'm sorry for this slide, it's in Spanish, but these are the main documents to be filled out so that one physician must be can have a membership, a SWOG membership. Yes, it's in Spanish so that all the Latin American group can understand all the formats here. Okay, and for investigators, they always must keep the following documents or data in hand. For example, it's that they, for SWOG, we have to manage the institutional email. So we have to check this email constantly because in a regular basis, you can get emails from SWOG or from CTSU. You have to know your username, your password, your SWOG ID number, and you have to know also your secret responses to questions for RCR. You have to get an updated GCP certificate also, and you have to keep in mind the dates to update your SWOG membership. And finally, you have to have an updated CV curriculum. These are the main websites, the most important. There are others, but these are the main ones. So this one is the first one. It's the RCR, where you can renew your membership in an annually mode. This is the SWOG. You also have the SWOG page, the SWOG site, where you can know all the policies, news about the meetings, everything from SWOG. And you have here the address or the main page for CTSU, where you can check all the protocols available in order to participate. Here, I decided to start with this RCR website because this is, I guess this is the most important one. So here you have the main page. You have to use your username and your password, and click in the I agree and login button, and then you enter to the site. Here you can have the first page that in which you can see your name. I cover all the personal data, but you can have the cover, the number. You can know here that you are an investigator, you are active, how much time you have of an active status. And here below you can have the main data from you.
We have 1 minute left, Dr. Mora.
Well, so in this page we can continue in order to follow all the, to complete all the data. I'm just passing very fast this. If you see here, there are many things asked or requested from the Institute to be filled. Until you get to the confidential financial disclosure form, and you have to fill out all of these. The practice preferences, sing and submit. And then you have to sign electronically here. Until you have everything ready to submit it. You finally push the submit the package button, and then you have this information where it says you have successfully submitted this information, and then you have to wait a little while to get this approval. And that's all for today.
Thank you, Dr. Mora. Well, with this last presentation of Dr. Mora, which just gives a general overview of the administration requirements for the PI, the responsibilities, and the need for monitoring the clinical research assistants, just to make the case that, as I mentioned in the beginning, Dr. Mora is the Senior Clinical Research Associate from SWOG in Latin America, and she will be more than happy to assist you in any further questions. Dr. Mora, I will kindly request to share this presentation to all the PIs and co-PIs of Latin America. And with that, I just want to thank you, everybody, from being here at this time in the afternoon after a long session of the SWOG in the spring term. And I think it is clear that we have a lot of opportunities to collaborate. We have a lot of enthusiasm in Latin America, and we definitely want to continue this work for being very active in clinical trials promoted by the SWOG in the US, and hopefully soon in specific protocols that are of big need within Latin America to take it to the central SWOG and get all the support from the United States to conduct it. So as just the last statement, I just again want to thank you, all the organizations from CRAF and from the operational office in San Antonio, and of course from the people that were able to set up, and all the members of the SWOG in the United States, and all the members of the Latin American countries that were present in this nice symposium. And hopefully the next time we will see you in person in Chicago, and if not next year in San Francisco. So thank you again. Have a good afternoon. And for the rest, I hope to see you next week in the course of clinical trials sponsored by the Mexican NCI and within SWOG. Thank you again. Un abrazo a todos y gracias nuevamente por estar aquí. Bye bye now.
Bye bye.
Bye.
Adiós.
Adiós.
Bye.